Hi, welcome once again to the deliberations of obstetrics and gynae with PrepLadder. Today we will be discussing about an extremely important topic in obstetrics and gynecology, something on which questions will always come. It is not that it may come from surveillance, it will always come from antepartum surveillance or intrapartum surveillance. So today let's just concentrate on the instrumentation which is used for this surveillance. Now, whenever I teach about surveillance, I would always like to emphasize the importance of surveillance. Look, anybody who is a doctor, he can be any specialty. He can be a physician, he can be a surgeon, a dermatologist. You ask any of these guys, what is the drug of choice for diabetes in pregnancy? He can easily tell it's insulin. Or what is the drug of choice for hypertension in pregnancy? He can say, let's say labetalol, he can say methyl-dopa. But any other doctor, can he monitor a patient, let's say from 28 weeks of hypertensive pregnancy and continue this pregnancy safely till term without any mishaps in the mother or in the fetus and give a healthy baby? Now, that is what something an obstetrician can do. Why? Because he can do the surveillance, the antepartum surveillance and the intrapartum surveillance. So, that is what makes an obstetrician. The capacity to do the surveillance properly and the will to stand next to a delivering woman. That is what is the purpose of an obstetrician, to stand in front of a parturient, isn't it? To help a parturient is the purpose of obstetrics. So, a person who can stand next to a parturient and make sure that the delivery is proper and the antenatal time from the time of diagnosing a severe disorder like an IUGR or a hypertension has gone off properly, and then the delivery was done in a way that there was a healthy baby delivered to a healthy mother. So, that is what is obstetrics. So, the crux of obstetrics, all the knowledge which you people take comes to antepartum and intrapartum surveillance. So, that is where intrapartum surveillance comes. It is something which is going to make sure that all the effort of carrying a pregnancy with IUGR or diabetes or SLE or hypertension has now come to the time of delivery. How careful you are at this time. That is what exactly is the importance of surveillance. Alright. So, let us start right away with this importance. Now, what are the factors which can affect the fetal heart rate? Now, this is a big boring list of things, but then we must know some things for sure. So, like what are the maternal factors? Physical activity, posture, uterine activity, body temperature, fever. Fever in the mother can cause tachycardia in the fetus as well. So, sometimes whenever we are doing the monitoring and if the fetal heart rate is in the 170s or 180s, we always check for the temperature of the mother, because that is a very important influence to the fetal heart rate. Fluctuations in the blood pressure, then fetoplacental factors like age of the gestation, umbilical cord compression, placental insufficiency, chorioamnionitis, infections causing fever again, and fetal factors like movement, fetal behavioral traits, stimulation to wake the fetus, like if you move the baby, that is if you tap on the abdomen and you shake the abdomen gently, then the heart rates can increase, and hypoxemia. Also exogenous factors like noise, medication, all have got effect on the fetal heart rate. Alright. So, apart from knowing this, how can we go ahead and do the monitoring of this fetal heart rate and of the fetus during the time of delivery? Now, I am very old fashioned. So, how would I monitor the fetal heart rate? Look, I am a little old fashioned in my methods, and I would still trust on my stethoscope or the Pinards Fetoscope to monitor the fetal heart rate. Even when the woman is in peak in contraction, in the peak of labor and breathing and having a lot of discomfort in lying down straight, even at that time, the stethoscope or the Pinard Fetoscope is one of the best instrument to get the fetal heart rate. And I would trust on the stethoscope more than I trust on the modern instruments, because you tend to over rely on the modern instruments and you forget your basic skill of catching a fetal distress by a stethoscope. Alright. So, the methods which we use in the labor room can be the fetal heart rate assessment by the Pinard Fetoscope. You can see the Pinard Fetoscope here. It is a aluminium instrument, and it has got a conical shape. The wide open part of the Pinard Fetoscope is put on the place where you are likely to hear the fetal heart sound. This woman was a right occipital anterior. So, you see we are putting it on this side of the mother's abdomen. So, this is how we go about this. We put our ear to the thinner end of this conical instrument and we hear the fetal heart rate, and I feel this is one of the ancient instruments and one very reliable instrument still. Every labor room, wherever you work, you will see the Pinard Fetoscope even even as of today, and it's one of the very reliable instruments. Do use this sometimes when you don't have a stent, and you'll see that you hear it even better with this one. But yes, it requires you to bend a lot and go very near to the pregnant lady, and sometimes it's not very convenient to the doctor or to the patient. So some people say it's easier to use the stethoscope. So when we have the stethoscope, this is the traditional way of what most of us would do in the labor room. Use a stethoscope to see the fetal heart rate. Of course, use the bell of the stethoscope because it will take the low frequency waves much better. So use the bell like is shown here by my resident, and once you have the fetal heart sounds reassuring, there's nothing more better in a labor room to go about. So what else we can do apart from using the Pinard fetoscope and the stethoscope? We can do internal direct fetal heart rate monitoring. That is, we can put an instrument right onto the baby and get the fetal heart rate. I'll try to explain you. We have a spiral electrode which is attached onto the fetal scalp. If you see this, there is an instrument like this with an electrode like this, and this electrode is attached to the fetal scalp. Now this is a bipolar spiral wire electrode which penetrates the fetal scalp, and the electrical fetal cardiac complex is fed into the cardiotachometer for fetal heart rate calculation. Now this is the basis of actually assessing the fetal ECG. The single probe ECG also you can get with this. So that's how we monitor the fetal ECG while the labor is going on, precisely only when the membranes are ruptured and the cervix is at least 3 to 4 centimeters or 5 centimeters dilated, then it is very easy to do this. Now what is better about this, that since it is an internal and a direct method of getting the fetal heart rate, it is going to muffle the maternal ECG complexes. It will pick up the fetal ECG complexes better, and the maternal ECG complexes do not interfere with our recordings. So that's why it is a much better method than the external methods which I am going to come to describe you later on this lecture. Okay. So this assessment of the fetal heart rate or the fetal ECG is known as the fetal electrocardiography, and we do the ST wave analysis. So it is simply called the STAN. This is the new fancy term which we use for the fetal cardiography. But when we are using this ST wave analysis, it can reliably tell us about fetal hypoxemia. So the mature fetus exposed to hypoxemia develops an elevated ST segment and progressive rise in the T wave height. And when there is still more severe hypoxia, then there is a depression of the T wave, and then with that we can know that the fetus definitely is in a distress, and we can go ahead and do a cesarean section to save this baby. Alright. So whenever you have these events of hypoxemia which are recorded in the fetal ECG, try and correlate them with the CTG. Sometimes the cardiotocography might show a very healthy uterine contraction and the fetal heart rate pattern, but this might be having a STAN event, that is, there might be some problem in this electrocardiography. At that time we must interpret this STAN along with the fetal cardiography. For example, if the fetal cardiotocography is going on fine, then we don't have to give importance to just one isolated STAN event, because these kind of STAN events or abnormal ECG patterns can come even if the electrode is not working properly, or there is a disconnection, or if there is a temporary movement of the baby and the signals have not been picked up properly. So any small event on the ECG does not mean that you will rush and do a cesarean section. You will always correlate with the cardiotocography. Alright, that's the best way to use this STAN analysis or the fetal ECG analysis. So that's one of the instruments which you can use. And then there is the external or the indirect method of assessing the fetal heart rate. Now the external indirect method of assessing is basically the Doppler instrument which we all know about. You know there is a Doppler which we can put on the maternal abdomen and we can hear the fetal heart rate. Now we have machines which can take this input of the Doppler and put it on a graph. So then it becomes a non-stress test. Now along with the fetal heart rate, if you also measure the uterine contractions, that becomes a cardiotocography. Alright. So let's not get confused in these. Use both of these terms interchangeably, like okay, do a CTG on this person, she's in the OPD. Now we don't call it actually a CTG. CTG is cardiotocography, cardiac of the fetus, toco of the uterine contractions. Graph of the fetal heart rate and the uterine contraction together is known as a cardiotocography. Do not confuse this with the non-stress test. Non-stress test means no stress on the mother, no stress on the baby. Simply put a Doppler probe on the tummy of the mother and note the fetal heart rate. So, yes, the ultrasound Doppler principle is that ultrasound waves undergo a shift in frequency as they reflected from the moving heart as you put them on the fetal body, and also by the blood getting ejected from the ventricles. So, the movement of this blood will also alter the Doppler wave, and that will be taken as a beat on the machines. So, the transducer is placed on the metal abdomen at a site where the fetal heart rate action is localized by a stethoscope. Alright. So, this is what the non-stress test equipment looks like. Now, I am trying to tell you about intrapartum surveillance equipment, but I am just mentioning non-stress tests now, okay, because you know about this instrument and you tend to get a little confused. So, why am I telling you NST? Because it is basically the same instrument. You know, if you look at this instrument here, this is a trace. You can see there is just one trace happening here, isn't it? So, there is a trace happening here, and there is a pregnant lady with a Doppler probe attached to her tummy. Now, this is where the fetal heart rate was localized, and this one lead is going into the instrument and it is catching the fetal heart rate, and the you know, the non-stress test is that whatever is the fetal baseline heart rate with the movement of the baby without any stress on the baby. That is why it is a non-stress test. With the movements of the baby, the heart rate can increase, and that increase should be at least twice in a 20-minute observation time. Now, that is the NST. All right. Now, NST, I am still with NST, although it is not intrapartum surveillance, just to avoid a confusion between NST and CTG. I am repeating myself here. So, when you have this NST, you must, or the CTG, you must always tie this with a, you know, there is a belt like this, elastic belt, so that you know, the elastic makes sure that this probe is, this Doppler probe is always in contact with the abdomen. Now, between the Doppler probe and the abdominal wall, if there is air, that is, there is a little bit of air between the probe and the abdomen, then the sound waves will not be picked up properly. So, air is not a very good conductor. So, that is why we use this gel. You must have seen this gel in so many ultrasound rooms. This gel is always applied under the Doppler probe, so that now there is a liquid medium, and liquid, you know, will conduct the sound waves much better. That is why gel is used. Okay. So, now this is the NST, and this is how we have seen. I am still telling you the NST, which is done in the antenatal period. Okay. So, that is the NST graph. If you have seen this, I am sure so many times in your books. Now, this is the NST where you see that there is this beat to beat variability. I will come to this, what is a beat to beat variability and what is a long term variability. I will come to that. Now, with the fetal movement, can you see this? There is a fetal movement here. There is increase in the heart rate from the baseline. See, this was the baseline. This was something around 115, and then it has gone up to around 150, 160, and then it has come down. So, this acceleration once, then twice, and some acceleration even later would have happened. So, this acceleration, which is at least 15 beats, more than 15 beats increase from the baseline, lasting for more than at least 15 seconds and happening at least twice in 20-minute observation time. You know, that is a reactive non-stress test. Now, I just revised non-stress test for you because we are trying to compare you know, non-stress test with the cardiotocography. Now, what happens in a cardiotocography, that the same machine, see, the machine has not changed. We have the same machine here. See, this is the machine here, and the same machine now will be used for making a cardiotocography. In cardiotocography, we have two leads, that is, we have attached two probes on the mother's abdomen, one for the fetal heart rate and one for the uterine contractions. So, see, there is one trace which is here, and there is another trace which is here. This is the uterine contractions. See, they are very, if you turn the you know, page a little bit in your mind, you will see that there is a mild contraction here and uterine contraction, and the corresponding fetal heart rate is recorded here. Okay. So, now this same machine is now used with two probes. Okay, I will show you on the patient. See, on the patient, you see there is one probe here on the abdomen which is taking the uterine contractions, and this probe, like the NST, is taking the fetal heart rate. Now, when you see two probes like this, that is what has come as a image based question in your exams, and some of you still answered it as a non-stress test. I am so sorry, when there are two probes, think in terms of cardiotocography. And don't say twins. I mean, nobody is trying to trouble you with asking there's a twin pregnancy with 2 probes attached and we are trying to get the NSG of twins. Now, that is really confusing yourself. We will not bother you with a twin question like that. So, when there are 2 probes on the abdomen, think in terms of a probe for the uterine contraction and 1 probe for the fetal heart rate, like shown here. Okay. So, this is how a reading of uterine contractions along with the fetal heart rate demonstration here. See, now this is the TOCO. Can you see TOCO? That's a TOCO, which is 76 units, and this is the fetal heart rate for the time being. It keeps varying, but it should not stay around 100 because that goes in, anything less than 110 is a little worrisome. So, you see it keeps moving, the heart rate keeps increasing. So, it should keep anything above 110, we are happy with it. So, you see ultimately the uterine contraction, when it was around 70-80, the heart rate had gone down a little bit and then it picked up. So, this is the uterine contraction and this is the heart rate, and this trace keeps coming on the recording paper. So, that is the cardiotocography. So, when should you be doing the cardiotocography? The instrument which I told you, let us see a little bit about the indications. Indication is when the patient is in labor, start the cardiotocography? Actually, no. Patient goes into active labor anytime after 3 centimeters. We generally mark the partogram around 4 centimeters and more. And when the patient is in active labor, that is not an indication for you to start all the instrumentation which you have in the labor room. That is an indication for you to see the heart rate by a stethoscope or by the Fetoscope, isn't it? You will not be using the CTG immediately when she goes into labor. When should you use the CTG? Late in the first stage. You know what is the first stage, isn't it? From the onset of the contraction to the full dilatation of the cervix, isn't it? And second stage is from the full dilatation of the cervix to the delivery. So, late in the first stage, when I have a patient who is around 5 to 6 centimeters, that is the time when because the contractions are going to be very intense at that time, she is in active labor, and then maybe the heart rate might go a little low with the contraction, and if it is too low, then I may have to take a decision. So, around 5-6 centimeters, late first stage of labor, that is when I start the fetal heart rate monitoring by the cardiotocography. So, should start in the late first stage of labor and during the expulsion stage. And but yes, there are some such situations where you would want to do the cardiotocography continuously moment you go into labor. Any high risk patient you would do that, isn't it? If you are in a tertiary care setup and you have too many high risk patients and you cannot individually see them very regularly, then a good electronic fetal heart rate monitoring with the uterine contraction is a good indication. So, oxytocin are administered during labor. I mean, you are inducing the labor with oxytocin and you are continuing the oxytocin, and giving oxytocin might suddenly cause uterine tetany, and there might be a very severe drop in the fetal heart rate, and you may miss it. You've just gone out after seeing the heart rate and you've gone out to see another patient, you've gone to do a cesarean, and some event happened to the baby. By the time you come, the event has gone, the heart rate is now normal, but these episodic hypoxic events which happen will cause the baby to go on pushing and straining and release a meconium and aspirate the meconium when he is delivering. Things can get complicated. So, that is why I say whenever possible in a high risk patient, do the continuous cardiotocography right from the onset of labor. So, oxytocin are used during labor that time when the patient has fever or there is bleeding in a case of let us say an abruption. So, it is an important indication for you to use the cardiotography from the beginning along with meconium staining of Leica, and green meconium, all of you know, is fresh meconium. So, that shows fresh distress, and a cardiotography can help you make a decision at that time. So, what are the basic patterns? Since we are discussing the instruments, might as well do a little bit of revision of the basic patterns which keep coming in your exams. Intrapartum surveillance is something on which always a question will come along with one question of antepartum surveillance. So, basic patterns, the heart rate should be anything between 110 to 160 per minute, and this should be recorded over 2 minutes so that we know the heart rate baseline properly. And then there is a beat to beat variability. Between 2 beats, what is the variability? That is, if it is less than 5 beats per minute, it is less than normal, it is minimal variability. I would want it to be between 5 to 25. That is known as moderate beat to beat variability. Incidentally, that is what is the normal beat to beat variability, and that is what is your answer in the exam. What is the short term variability or the beat to beat variability? It is 5 to 25, and more than 25 is more beat to beat variability. Okay, what is beat to beat variability? Let me try and explain this to you. Short term variability, the variation in the heart rate by every beat. Alright, if there is a heart rate, like if I see your pulse rate now, your pulse rate would be like tuck 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 tuck, it will be like 72 beats per minute, isn't it? But a baby's heart rate is constantly varying at the baseline because of the sympathetic and the parasympathetic play between these two systems. So, what happens if there is a heart rate of a baby, you continuously measure it over a duration, you will see between 2 beats the heart rate will vary. That is, suppose there are 2 beats like tuck tuck, you get a heart rate of 130, or it is tuck tuck, so it becomes 140. So, between 2 beats, the time gap between the 2 beats will also change the rate of the baby, isn't it? Between 2 beats there is a variability. Okay, let me try to show this to you even more closely. Can you see this? The heart rate, it's going, it's not like a straight line, it's going like this, isn't it? And then it goes low like that, and then it goes low again, and then there is a acceleration, isn't it? So, even when there is acceleration, can you see it is not like this, it is a ragged acceleration, because even when the baseline, suppose the baseline here is like suppose 140, now it has gone up to 160, there is an acceleration we can make out, okay. But there is an acceleration, the baseline for 140 is gone to 160, but the beat to beat variability will continue. So, short term variability can most reliably measure with a scalp electrode, you know. You can also measure it the way I have done it here in this example. It is done by the Doppler instrument, and that is this NST trace, which you know very well. This NST trace is by the Doppler on the abdomen, but if you want to know the beat to beat variability best, you may get a question sometime. It is by the fetal scalp electrode, which I showed you in the beginning of this lesson, okay. And long term variability is used to describe the oscillatory changes during at least 1 minute and more. So, long term variability, the heart rate changes between 2 minutes, that is from 1 minute what was the heart rate and next minute what was the heart rate. Now, that is a long term variability, and between 2 beats, beat to beat variability, that should be there. That says the fetal sympathetic parasympathetic system is good. Let me tell you another way of understanding this. Sometimes when we are doing the non-stress test, you may see a baby sleeping and he is not moving. If the baby does not move, acceleration does not happen. But I am not worried when I see a baseline something like this. See, there is a beat to beat variability is there, and this increases like that a little bit, although this is not acceleration, but the beat to beat variability is there. Okay, he is sleeping, let him alone. It should not be something like this. If it is like this, then I am worried, because the beat to beat variability is very less, baby is definitely having some problem, some hypoxemia, some distress, something is wrong, alright. So, short term variability, long term variability, I have tried to make you understand here. Let us move on and see. So, these were the basic patterns of the fetal heart rate and their variability, short term and long term. Let us see the patterns on the cardiotocography, alright. I will do a quick revision for you. So, let us see, this is the toco, that is the graph of the uterine contraction, and this is the fetal heart rate. So, suppose the uterine contractions are like this. So, along with the uterine contraction, what happens to the heart rate? Of course, the heart rate would be having this beat to beat variability, and with the uterine contraction the heart rate goes low and then picks up. Again with the uterine contraction the heart rate goes low and then picks up. So, you may see a pattern like this on the cardiotocograph. Pattern 1, type 1 deceleration on the cardiotocograph. Now, we are discussing intrapartum surveillance only. NST was just told so that you can compare between NST and CTG. So, CTG is in labor, and I am trying to tell you what type of deceleration you may see in the fetal heart rate. So, with the peak of this contraction, that is the highest contraction strength, at that time the heart rate has come to its lowest, which is known as the nadir, okay, the lowest point. The lowest point is known as the nadir. So, the peak of the contraction is coinciding with the lowest fetal heart rate. Now, that is what is known as a type 1 deceleration. Now, this is a normal type of a deceleration seen in all active labor. In active labor, you can see this, especially the 4 to 8 centimeter time of labor. Why? Because of head compression. The head compression causes vagal stimulation, and vagal stimulation reduces the heart rate. So, when the uterus contracts, the head is compressed and the head is trying to enter in the pelvis, and that time even if it is in the pelvis, the head compression happens and that causes vagal stimulation, heart rate goes low, and this is a normal thing. Now, you may say, sir, how can deceleration be normal? Now, I do not want to tell you all the patterns and then trouble you about this fact. All of you, whether you were my students in whichever forum or you were students on PrepLadder, please understand the difference between deceleration and distress. That is where you people get confused so many times. We are discussing type 1 deceleration. What is acceleration? We discussed in NST. Acceleration is any increase from the baseline by more than 15 beats, lasting for 15 seconds. So, what is deceleration? Any reduction in the heart rate more than 15 beats from the baseline. What is the punchline here? The baseline. We are not talking about distress. Okay, if the baseline fetal heart rate is 120 beats per minute, let us say this fetus is at 150. Now, there is a reduction in the heart rate with the uterine contraction. Now, this reduction is more than 15 beats from the baseline, it reduces. Suppose it goes down to as much as 130. Is this a deceleration? Definitely, it is a deceleration. From 150 is down to 130. It is 20 beats lesser. But is this a distress? No, it is not a distress. Now, that is why you people keep getting confused and use these terms interchangeably. I'm so sorry, especially students who are getting into medicine and doing internship or getting to first year or post graduation of gynecology. They miss this sometimes and disasters will happen, or too many cesareans will happen. That is also a disaster. You are doing too many cesareans because you thought this is a distress. Distress means any heart rate less than 110. Didn't I tell you just now in 3 slides before? So, any heart rate which is less than 110 is distress. So, we are talking deceleration. Heart rate going from 150 to anything less than 135 would be deceleration. So, 15 beats reduction from the baseline is deceleration, and this is a normal type of deceleration which happens with head compression. Alright. With this, I am not going to do any intervention. I am going to look at this, I am going to observe this patient and continue the progress of labor as it is going, because it is a normal type of event which can happen. Now, what is type 2 deceleration? Now, this is a little tricky. With the uterine contraction, the heart rate again goes low. Of course, it goes low in the same beat to beat variability. But the deceleration, the heart rate would be having this beat to beat variability. The deceleration happens after the peak of the uterine contraction. Okay. Once again, after the peak of uterine contraction, and then it picks up. So, the peak of the uterine contraction and the nadir, the lowest part of the heart rate, they are not coinciding. In fact, this event is much later than this event, isn't it? That is why it is late. That is why it is called a late deceleration. Now, when there is a late deceleration, what does this mean? The uterus has a placenta which is not able to supply the fetus too well. That is the basic meaning of this. I will try and make you understand once more. If you see this, the uterus is having a fetus and a placenta here which is giving the blood supply to the fetus. Now, when there is a uterine contraction here, can you see, when there is a uterine contraction from all the sides, a uniform uterine contraction, now that contraction is going to compress the placenta. Okay, I will try and show you this way. It is going to compress this placenta. When the placenta is compressed, the blood flow will reduce. But this placenta is having calcific blood vessels. It is a patient with IUGR, it is a patient with severe hypertension of pregnancy. Now, in that situation, the blood vessels are not very big diameter, they are small diameter blood vessels. So, when the uterus contracts, the blood starts to go out from the placenta, but very slowly, because the vessels are very narrow, and the placenta empties slowly. So, the heart rate, the blood supply reduction to the baby happens slowly. That is why the heart rate goes down much later. Now, when the contraction stops, the placenta should refill and immediately start giving blood to the baby. Now, the refill is also slow because the blood vessels are calcific. So, that is why the emptying is slower and the recovery is slower. That is why this placenta is insufficient, isn't it? So, that is why whenever you see this pattern, you get worried. Is it a distress still? It is not a distress. See, it is 150, it has come down to 130, it is still in the normal range of the fetal heart rate. 110 to 160 is normal, but it has come down in a pattern which is not good. This pattern I do not like. See, I like this pattern, early deceleration, but I do not like this pattern, late deceleration. Why? Because it is happening later because of the insufficiency of the placenta. So, this is type 2, it is seen in placental insufficiency. All right, fine. Now, see this and tell me what type of deceleration is this. There is a heart rate, it is having a good beat to beat variability, and then the heart rate goes low. Can you see this? And look at the uterine contraction, one contraction, second contraction, third contraction, and exactly this is a textbook case. This is as recent as 9th of September when I saw this patient. One of my residents picked this up, and of course this patient ended up in a cesarean section, and thanks to her I've got this nice picture for you, original picture from my hospital. You see this uterine contractions and the heart rate going low and then picking up. See how late it is. It is not coinciding, and then the uterine contraction has settled and then it picks up much later. Another uterine contraction, again a late deceleration. Another uterine contraction, a late deceleration. So, this is what I explained just now to you, a late deceleration. And this patient, you see the heart rate was going less than 100, almost going into the 90s. So, that is why any deceleration I can still observe for some time. But if the deceleration is going repeatedly under 100, then I know she is touching distress repeatedly. Now, repeated episodes of distress, we end up doing a cesarean section, isn't it? So, with deceleration, you can give some time. You may end up in cesareans for these late decelerations most of the times, that is the truth. But if it is going beyond 110 and touching 100 and much beyond 100 repeatedly with the contraction, then you may have to take a decision much earlier. Okay. Now, there is a third pattern which all of you know very well, and that is the variable deceleration, and this is called a abrupt change in the fetal heart rate lesser than the baseline, and lasting more than 15 seconds and going more than 15 beats below from the baseline. That is known as a variable deceleration, but it is abrupt. Why? Because it takes less than 30 seconds to go from the baseline to the lowest. What is this 30-second funda? See, all these events which I showed you before, you know, this uterine contraction and the late deceleration. So, this event, this takes more than 30 seconds, all right. From this to this, it takes more than 30 seconds, all right. And this event should not last more than 2 minutes, we know that also, but this event takes type 2 deceleration or even the type 1 deceleration takes more than 30 seconds from the baseline to go to the lowest heart rate, to go to the nadir. Now, here this is known as an abrupt variable deceleration. It is known as abrupt change because it happens very fast and it takes less than 30 seconds to go from the baseline to the lowest. Okay, let me draw and tell you uterine contractions. Now, it may or may not be associated with the uterine contraction, it may happen by its own. See, this is what is variable. This length, can you see? Okay, I will try and draw and tell you. See this length of deceleration, see this one. All these three are variable, it is not the same depth of deceleration. You see this? This is almost the same depth, all these three decelerations. That is why it is type 2 deceleration. This is variable. This is smaller, this is bigger, the second one is bigger. Okay. So, when there is variable deceleration, we think in terms of cord compression, and cord is a long organ and it may 50-60 centimeters and it may come under the abdomen or come under the legs, it may get entwined, but cord has got a lot of protection, it has got the Watten's jelly. So, any cord getting compressed does not mean that it is going to cause distress. So, variable deceleration is the most common type of deceleration. Yes, that is the MCQ you get, is the most common type of deceleration, and we are not worried about it too much. Yes, variable deceleration, we are not worried about it too much. These events which are happening from the onset to the peak of the reduction of the heart rate, the lowest part, that happens within 30 seconds or less than that, and then this whole event gets over in less than 2 minutes, then are not worried too much. But if it is lasting more than 60-70 seconds and it is going more than 2 minutes, if these events are getting prolonged, then I am worried even with variable decelerations, then the cord is probably getting too stuck or too jammed somewhere. Okay. So, variable decelerations, what is the essential that you should know? that when I am doing cardiotography in labor, variable deceleration I will see most commonly and they are harmless. But if they are lasting long, then I am worried. There might be some other patterns, might as well discuss them today itself. So, the heart rate may go low and pick up, but this may show some reassuring patterns that before it goes down, it has a shoulder. When it comes back, it has another shoulder, then it goes to the normal heart rate baseline. So, these are the shoulders. These shoulders are telling us that the fetal heart rate is compensating well for these decelerations. Okay. So, this much is okay still, but sometimes these decelerations may have overshoots in recovery. Now, this much is called a overshoot. When there are overshoots, then we are not liking this. So, shoulder is reassuring, overshoots are not. So, this has not been asked as an MCQ so far to you, and I doubt if this is picked up by too many people who are very young residents. Sometimes they also miss this, but it is something to look at. Variable decelerations, all of us tend to ignore them because they are common and they are the most common. But yes, if they are lasting too long, then before a disaster happen, we can think in terms of doing a cesarean section. Okay, so shoulders are good, overshoots are bad. Okay. Now, what is the sinusoidal or the sine wave pattern which we see on the cardiotography? The fetal heart rate does not have the beat to beat variability. See, it is an undulating sine wave kind of a pattern, and this serrated beat to beat variability which I told you is not happening. This is not seen. So, this 3 to 5 smooth sine wave type of pattern in the fetal heart rate baseline and persisting for 20 minutes or more. This is definitely fetal distress, and this sine wave pattern is generally seen in severe fetal anemia. Patient with RH isomerization will have a hemolysis, and that kind of patient will have this sine wave pattern. This is not normal. I would do a cesarean when I see this. Well, I am not going to go into so many other patterns which we know. So, let us get back to the monitoring business which we were doing with this class so far. So, sometimes we think that when we have this cardiotography monitor and we can substitute all the monitoring by just putting these two probes on the abdomen, and we can see the heart rate and we can see the uterine contraction, and anything goes wrong we will take action. Then we became very smart. We thought, then why not all the 10 patients in the labor room, why not put 10 CTG machines and just put them on a central monitor. You do not go to the labor room at all, you just tie her up with this. The nurse is sitting next to the patient and just talking to her and counseling her, and you are sitting in your station where you have all the 10 monitors together in a big screen, and you keep looking at that occasionally. Actually, that would be really very convenient for the postgraduates. Actually, if you have all of these kind of monitors, what would the PGs in gynae do? What are they going to monitor then? The fun of obs in gynae is to stand next to the patient and observe her and monitor the fetal heart rate, and that is what is going to go out when you have these kind of monitors. But that is not the only thing I am talking about. Okay, fine, I am old fashioned, I want the residents to work hard and I want them to see, okay fine, that is how a professor thinks. But besides this, it has been proven way beyond doubt, when you have a central monitor and you have all these CTGs put together so that you can monitor them in one room, maybe not even in the labor room, you can be remotely sitting in some other place and you could be monitoring them on a screen. That is not known to increase the outcome of the deliveries. It is not going to do any changes. In fact, you may end up doing more cesareans, because anything which goes up and down, you think in terms of doing a cesarean. So, this is not going to increase the survivability or the neonatal outcome by doing this continuous monitoring of all the patients and put together and monitor them in a central monitor. So, this was tried, there was a very good study, and this proved this not to be of any good use. Alright. So, the results showed that the detection accuracy has actually declined, and the number of displays as they increased, the assessment capacities of these doctors actually became even worse. Okay. So, thank God this is not in vogue, and I am very happy for that. So, one central monitor, definitely not the best. Then another method of taking care of the fetus is to measure the pH of the fetus directly. Now, how is that possible? fetal scalp blood pH. If you see the fetus, it's suppose here the cervix is open around 5-6 centimeters, and you can easily do this by putting a probe into the vagina, and this probe goes as close as possible to the fetus. It's a sharp probe, and with that you make an incision on the fetal scalp. When you incise the fetal scalp, you get some blood out, and you get that blood directly sucked into this probe, and that is going to tell us the pH. To make sure that the blood does not trickle off, you apply some gel on the fetal scalp. So, moment you make a cut, the blood comes under the gel, so it does not trickle off, it makes a small blob kind of thing. So, you make sure that you just suck in this blob, and you do not lose the blood. So, do not make a very big cut on the fetal scalp, small cut, you get the blood, and then you check the pH. So, that will give us a very good assessment of the fetal condition. Generally, the pH of the fetal blood is lesser than the umbilical vein. Okay? The umbilical vein, which is the oxygenated blood, the pH is a little lesser. So, how do you interpret this? The algorithm says that the pH should be more than 7.25. That is what is acceptable for a fetus. Anything more than 7.25, the labor is continued. Okay? You continue the labor and do not do any interference or any intervention. Now, if it is between 7.2 and 7.25, now I am worried. Coming close to 7.2, I am worried. So, the pH measure is repeated within 30 minutes, and if the pH picks up, generally what we do, we put the patient in left lateral or right lateral, so that the baby moves away from the inferior vena cava, and the flow to the heart increases and the output increases, and the oxygenation to the baby increases. Also, we give some oxygen to the mother. We start running some oxygen at 2 to 4 liters per minute. And if it increases the oxygenation of the baby, then we know that it was a temporary event. But now, if the acidosis is not improving, then we may have to take a decision. So, that is why repeat within 30 minutes. Now, anytime the pH is less than 7.2, that is frank acidosis for a fetus, do a cesarean section. That is what I say. Although the recommendation here is that do another scalp blood immediately to just counter check what you just saw, but prepare the mother for surgery, do the preparation for a cesarean section. I am not as of now we are discussing instruments, and I told you a little bit about the heart rates, and instrumentation is what was the idea of this class, but I am not going to the guidelines of CTG and the guidelines of interpreting and monitoring and the guidelines of managing a patient based on the fetal scalp blood pH or the STAN or the ECG. I am not getting into all that, because those guidelines are so varied between the colleges, and they are not of any use to you because they have not come in the exams. What has come in the exams? The scalp blood pH has come, and the fetal ECG and the cardiography has always come in the exams. So, those are the important things, and I am not getting into the discussions on the controversies in intrapartum fetal surveillance here. So, another scalp blood sample is taken immediately, and the mother is anyway prepared for a cesarean section. The only benefit reported for the scalp blood pH testing are the fewer cesarean deliveries, and that is what I like to see, isn't it? Lesser cesareans and more normal deliveries. So, this is a good method of keeping an eye on the fetal pH. Okay. Now, there is another one known as the vibroacoustic stimulation. Remember vibroacoustic stimulation we also read in our chapter in antepartum surveillance. Now, vibroacoustic stimulation is a good substitute for fetal scalp blood pH, because this is invasive and you have to go and make a nick on the fetal scalp and take out blood, and it can cause some infections, and it is best that you try and do non-invasive methods. That is what a lot of people would think. So, this is an electronic artificial larynx. It makes a bucking kind of sound. That bucking kind of sound is kept, that sound maker, it is kept as close as possible to the metal abdomen, and that sound is known to startle the baby, that loud noise, and the baby gets startled, it is like, oh, what is that? So, when he moves, the heart rate increases. That means he is able to hear, he is able to react. When he reacts, the heart rate increases. Good sympathetic system, heart rate is increasing, I am happy this baby is healthy. That is the way to look at the vibroacoustic stimulation test. So, it can be done antenatally in the antepartum surveillance or also the intrapartum surveillance. So, it is a substitute for fetal scalp blood sampling. Response to vibroacoustic stimulation is considered normal if fetal heart rate acceleration of at least 15 beats, lasts for 15 seconds within 15 seconds of the stimulation, just like you discussed about the acceleration in the nonsense test. Also, the same can be used in the intrapartum surveillance. Alright. Another method is the fetal pulse oximetry. The principle is just like the pulse oximetry which all of us go through, and these days with the disease looming all over us, pulse oximeters are there in every household, I think now. So, something similar is happening in the fetal pulse oximetry also. We have a pad like sensor which is inserted through the cervix on the fetal face, and this registered the fetal oxygenation in 70 to 95% of cases. Now, the normal oxygenation, see, we want our oxygenation to be anything more than 95 on room air, isn't it? Anything more than 90 we are happy in the ICUs, and less than 90 we start getting worried, isn't it? Of course, your physicians are teaching you so many things about that, and I am not the right person to talk about that in detail. But what I can tell you, that when I am using the fetal pulse oximetry, this is reliable as long as the fetal pulse oximetry is showing me oxygenation of 30% and more. As low as 30% for a fetus is fine. Now, this is what is new for us, isn't it? For an adult, and if you see anything less than 90 we are worried, and less than 80 we start doing major interventions, isn't it? Here, low limit for normal fetal oxygen saturation is considered to be 30%, and less than 30% for more than 2 minutes is considered ominous. Alright. So, these are the ways by which I can do intrapartum surveillance, and I can make decisions, and I can decide for doing cesareans or letting a normal delivery happen. But remember, none of these methods should replace your capacities to use your stethoscope or the fetoscope and try and catch these events before they become very severe. Alright. So, do not forget that the best assessment is the obstetrician who is sincerely monitoring these patients, and those obstetricians have always done better than the ones who are relying. Remember, I told you about the continuous fetal heart rate monitoring on combined monitors. They have actually shown us things will actually get worse and no better outcomes have come. So, yes, continuous electronic fetal monitoring. What is the biggest drawback? Suppose you have got one fetus and you are doing one patient in the labor room and you are doing continuous monitoring and you are very careful with your monitor. Actually, if it was not indicated and you are doing a very close monitoring with the cardiography, you will end up doing her cesarean, because moment the heart rate even just varies a little bit because of some variation in the machine picking it up and some wrong reading, you may actually interpret this as a major disaster and do more cesareans. So, yes, continuous fetal heart rate monitoring, I have told you what are the indications, and the best monitor is the obstetrician with his stethoscope. Alright, I hope this was useful, and we will meet across with more lectures. All the best and do well always. Bye bye.